And for your patients that also present with chronic rhinosinusitis, we said a lot of them will also have postnasal drainage and nasal congestion. They might also have a scope that has some edema and swelling. How do you distinguish how much is, the difference between the two, chronic rhinitis and chronic rhinosinusitis? And then how do you know how much the chronic rhinitis or maybe the CRS is contributing to the postnasal drainage? Like, how do you think about those? And
Exactly.
Right? Do I need to do a posterior nasal nerve ablation if the issue is CRS? And how do I know?
Yeah, exactly.
Right?
Exactly. And that's so hard to tweeze out, right? Because they're so interplayed. Because anyone that has chronic rhinitis, a lot of times what we know about chronic rhinitis, chronic rhinitis, this is a little bit different from acute recurrent sinusitis, right? So chronic rhinosinusitis, what we know is that it's much more of an inflammatory issue, right? For some reason, they have some overdrive in their system, which is causing a lot of inflammation, and that presents as inflammation inside their sinuses. And downstream of that, what that causes is inflammation inside their nose. Right? Because the main symptoms we're looking for chronic rhinosinusitis are nasal congestion, nasal drainage and discharge, loss of smell, facial pressure, and pain, right? And you can see those first two symptoms heavily overlap with chronic rhinitis. Right? And so probably a lot of those patients who have the chronic sinusitis downstream is causing that inflammation inside the nose itself, leading to that nasal obstruction and drainage and discharge. Right? So I do think a lot of people do have that interplay. And we know that doing chronic sinus surgery does help a lot with their rhinitis symptoms as well. So I think your question that you've landed on is really, really key. When do we add that extra nasal nerve ablation procedure to the sinus surgery? For me, I think it all goes down to what symptoms are bothering them the most, right? Is it more the loss of smell and the facial pressure or pain? That tends to be much more from the sinuses, right? The nose itself doesn't cause too much of those symptoms. But if it's more the obstruction and especially that drainage and discharge, right? Because I've definitely had patients. I remember early on in my career, like this very, very key moment when I had my first quote unquote kind of like patient who I did good surgery on, and they came back still with complaints. Right? And how crushing of a feeling that is, right? Because here you are, I just finished fellowship, I did the subspecialty training in sinuses, right? And so I feel pretty confident in my surgical abilities. I took care of the sinus disease, yet the patient still feels miserable, and so that's soul crushing, right? And so now
nobody teaches you that.
Yeah, exactly.
Nobody teaches you that.
Exactly. Yeah. So now I try to tweeze out how can I maximize the potential that this patient is going to benefit from surgery, right? Because here they are, they've already taken time off of work, they've already invested their time and money into committing to a surgery with me. I want to make sure that the patient gets a maximum benefit from that one procedure. Right? And so if someone comes to me and they have a lot of issues with that drainage and discharge and that congestion, then a lot of times I do consider doing something simultaneously to those posterior nasal nerves to kind of maximize that benefit. Right, because the procedure itself is relatively low risk. It's pretty, and it doesn't really add much to the recovery time.
And when I think about the areas that are treated when you do like a PNN ablation, and I think about some of the other surgeries we do in ENT, do you think that there are some times when we are kind of treating the nerve and not knowing it?
I'm sure.
Yeah,
100%, right? Because
before we were thinking about the nerve, maybe some patients were benefiting from their procedure also because of, maybe some nerve branches got hit.
Especially if you do a wide maxillary enterostomy, right? You're already cutting part of that lateral wall where some of the nerves are going, right? Especially posteriorly. And so I'm sure you're cutting some of those nerves. And then you're addressing, especially if you do turbinate surgeries, right? You're addressing the end organ, right? The organ that's being stimulated by those posterior nasal nerves. So yeah, absolutely. We're definitely addressing it in some capacity, even before we had this procedure specifically for the nerve.
And so I guess let's talk about the procedure itself. I mean, we have somewhat, but, in general, kind of backing up a little bit, there's a few different tools available to address the posterior nasal nerve, and then we can kind of get into specifics.
Yeah, absolutely. Yeah, you're absolutely right. So there's a couple of different devices out there on the market to address that nerve. There's kind of three primary ones, right? There's the RhinAir, which is the radiofrequency ablation. There's the ClariFix, which is cryotherapy. So that's freezing the nerve. And then there's the Neuromark, which is also a radiofrequency ablation, except the device looks a little bit different. Right. And so with the RhinAir, it's a single probe with a malleable tip. So you could be very, very precise with it in addressing multiple in those locations where you think the nerve might be. With the ClariFix, essentially it's a balloon that blows up with, I believe it's nitric oxide. Right. So that freezes the surrounding mucosa and the nerve underlying it. And with the Neuromark, it's also radiofrequency, but rather than a specific probe, it uses kind of like it almost looks like leaves, like a little basket, right there, where it kind of all those leaves should theoretically touch that sidewall and hopefully maximize the chance of you capturing that nerve. So definitely pros and cons of each approach, right? I think the RhinAir, it's very malleable. You can guide it exactly where you want it to be. I think the ClariFix, it is very effective. It's faster. Right. However, the downside is about 10% of patients will get this really severe ice cream headache. Right. And this ice cream headache, it can be pretty bad. I've tried a lot of different things to kind of prevent it. I've tried like having people sip on like warm teas, tried like warm liquids. There was a paper that actually I think Dr. Su, he was on your podcast a little while ago.
He was.
Yeah. He wrote a paper mentioning gabapentin. You had people take that before the cryotherapy. I also tried that as well, but despite all that, no matter what I try, a certain population still seem to get those ice cream headaches. Yeah. And it's not just like, do you remember like if you eat ice cream and you get that brain freeze, or for me, it was
it's a couple seconds
back then when it was a thing, right? It would last for a couple of seconds and it would go away, right? But for this one, it would last for like hours sometimes, right? And that could be really excruciating for the patients, But I do think it is very fast and efficient, so I still occasionally do the cryotherapy as well. And then the Neuromark, it is faster than the RhinAir because you do like a single spread of those leaves. However, I think the one advantage the RhinAir has over the Neuromark is that being able to address other structures at the same time, right? So RhinAir, not only can you do the posterior nasal nerve, but you can also do a turbinate reduction at the same time and do a septal swell body reduction at that same time as well. So you're able to address 3 anatomical issues in one procedure.